where it was short distal left main disease was a simple one-stent approach. That's different than this complex left main bifurcation, which ended up being an upfront two-stent approach. So the summary is using one stent versus two stent. Well, using a provisional approach is probably the right approach in lower complexity disease. But the most important piece is judging the complexity of the disease, where if your disease complexity is higher, those are individuals who may actually do better with an upfront two-stent approach. And the big differentiator is the severity of the side branch stenosis and the importance of the lesion length in the side branch, where if you're over 10 millimeters, you're probably looking at an upfront two-stent strategy. Thanks very much. Sorry about going over time.
Thank you, Dr. Shunti Prella, for nice deliberation, single stent versus two-stent strategy. Any question from the audience? So I'd like to request Professor Jafar sir, yes.
Aisha.
Yes, Aisha.
Excellent talk as always. I think a comment and a question. That's right.
Dr. Aisha, you can proceed.
I think somebody would have to take the mic over. Okay.
PCI versus PVD, also compressed plastic. Now, it's very important for juniors and also for doing left main. Justice must be done first to the patient and to yourself. If you violate justice once, you violate justice for the rest of your life. What is justice? Justice means what the patient wants, how much I know about left main. What should be done to the patient's benefit financially? The stent expenses and CMD expenses in cardboard countries must be balanced. What the patient wants, what is the age, what is the output from this economic output of this picture? Whether this man will be able to return his economic and physical and quality of life after spending so much of money selling all the lands and everything he has got available. So in complex angioplasty and left main is not a very frequent place for intervention. Sometimes the operator wants to start doing left main without having a past experience or maybe he doesn't have anybody around him. So in this country, please, my request to you is this: do justice to yourself, how much do you know the work? Do justice to the patient and his family, what should do for this. Thank you very much.
Yeah, thank you, sir. This is very important. Yeah. Dr. Aisha?
I think it boils down more not just to the two different patient subsets, but also two different philosophies, given the fact that we are looking at more extensive disease in the region and that regionally people here are better operators. But I would really like to revisit the question of kissing balloon inflation. For example, in EBC main, after the POT, a kiss was mandated. So we don't really have enough data from, say, non-left main or Nordic 3 to mandate kissing balloon inflation after a single stent strategy. At the same time, there's also the issue of fenestrated restenosis. So how do you reconcile this issue of kissing after a single stent strategy? And that's a question for the whole panel, please.
Yeah, so I mean, I have thoughts on that. That's a very advanced question from obviously someone who knows a lot about this area. Do you use a kissing balloon inflation at the end in your provisional strategy, or don't you? And I think ultimately, to me, that comes down to using the same criteria the definition put forward, which is if you have an impediment to flow into your side branch, given that at bifurcations that's where you get eddy currents and that's where you end up getting restenosis, you're obligated to relieve that obstruction. You can use physiology to define whether or not you need to do that, and that's typically my approach. I think it's perilous to dilate a vessel that you're not prepared to stent. But if you have a reason to treat a vessel, so not dilate, treat a vessel, then treat it. And if the treatment you choose to use is a low-pressure balloon dilatation to open struts covering the side branch, that's reasonable. That, I mean, when you suss out what happened in DK Crush, right? Even the simple bifurcations did better with the two-stent strategy. And the question is, maybe that's because both vessels were fully open and there was normal physiologic flow. And I think you raised the point correctly that we don't have the data yet to answer that question, but we probably will when DK Crush 8 comes out.
Yes, thank you. I'd like to request Dr. Vanita Shah,
Yeah, Dr. Vanita.
your comment and your message to the junior fellows regarding the left ventricle staging, what precaution and how they should proceed to stent the left vein in bifurcation to the juniors. Your comment and your message to them. Dr. Vanita Shah.
So without repeating, the entire talk here, I think the key points here are that have been made so far that I definitely want to highlight is looking at the entire patient, their comorbidities, extent of disease beyond the left main, right? So when we're talking about left main bypass versus PCI, patients don't live in isolated left main. If they only have an isolated left main disease, that's amazing, but more often than not, they'll have some multivessel disease, and whether or not that also can be treated with PCI versus bypass. And then the final thing that I'd highlight is that honestly, I know we're going to get into this debate about imaging into left mains, but I think anyone who can say that they can differentiate between a 4.0 millimeter and a 4.5 millimeter by angiography and eye alone is very confident of themselves. I think that's very, very hard to do. The bigger the left main, the bigger the size, the harder it is to make small discrimination. So I think in those cases, imaging is incredibly important. I personally am more of a provisional strategist unless there is a significant disease in the osteal circumflex going into extending longer, as Sanjog mentioned, longer than 10 millimeters. I'll usually go provisional. And the only thing that I had mentioned earlier that I would differ on is that I started to do a pre-kiss with a balloon that's half the size smaller in the side branch before putting the stent in the main vessel, just to be able to re-access the circumflex easier in a provisional strategy.
I do understand our honorable Dr. We are trying to customize this program because we are...
Yeah, we're running short of time. So our next speaker, Professor Mir Jamaluddin. Professor Mir Jamaluddin is the Director of National Institute of Cardiovascular Disease. And he will be talking on place-based approach for choosing the correct twisted strategy. Twisted strategy, which would be chosen according to the case individual.
So, thank you. My computer is in process. I am happy to tell that I am in the ocean of interventional cardiologists, including the world vision interventional countries, interventionalists from different countries of the world, including our country, arranged by Sky, and I am grateful to Sky for arranging this program. The outside it was running, but in the inside it is not.
Sorry, I'd like to request Dr. Umar for his comments. Dr. Umar.
So while we're waiting, I guess I'll ask the panelists here, how often are you doing your left main femoral versus radial? Does it matter to you in terms of access site?
Yeah. In my laboratory, in my cath lab, most of the left main, especially when the bifurcation is the issue, we used to go to the femoral lattice. And for other than bifurcation, especially in the shaft, the access may be operators. Majority of our operators are femoralists, but I do it through the radial.
We do radial for all left main. Radial for all left main.
Yeah, us too. We're predominantly radial lab, and you can do all of the bifurcation strategies except for simultaneous stent inflations. You can do it through a 6 French guide, but we've often taken 7 French guides with a radial without any problem as well. So for us, at least at our lab in New York, we'll predominantly do via radial access.
I agree with you that if it is okay, we can do provisional technique. That's for sure. But sometimes you might have very rich serve, and in that time, if you need stand, it's obvious it will be very difficult to send a stand to serve, right? Could be. So in that case, I do 2-step technique. Even I could do provisional technique if I need a second stand to serve. I know that it will be very, very difficult. So I think everything regarding the anatomy, right? Of course, if it is provisional, you can do provisional, but it doesn't mean that I will do provisional. If not, I'll do 2-step technique. I don't think it will work. So for left main, because of the 2 branches very big, restenosis bacteria is very low. And also, I'd like to tell you, in my opinion, it's easier to do left main bifurcation rather than to do OM circ or LA diagonal because it's bigger. You can cross easily, you can send balloons easily, everything is more easy. Of course, more risky, but it's technically easier.
What is your catheter choice for left main bifurcation? Is it subcutaneous, is it EBU, or
EBU, I always use 7 French. I use 7 French. Although I can do 6 French, many things, but I switched up to 7 French.
your opinion regarding 7 French or 6 French, EBU or European catheter for left main bifurcation?
Yeah, I mean, I'll have to admit, for the most part, I have still been doing 6 French EBU, with the minority of cases going up radially with a 7 French guide. You can get some trouble. I had this issue once where you're trying to take a larger balloon, like a 4 or 5 balloon for the main branch, and maybe a 3.0 balloon or a 2.5 balloon, depending on how big the stroke is, for the side branch. And that can be tough sometimes during going through a 6 French. So what I learned was if you put in the larger balloon first, then you're more likely to get the smaller balloon through the 6 French. But in those cases, honestly, a 7 French just makes it easier.
So, technical issue has been solved.
That's it.
I'm extremely sorry for inconvenience. Because I know of this thing, and that is why I have tried thrice, here, outside, and here. Even then I failed. My topic is case-based approach for choosing the correct 2-step bifurcation strategy. Regarding bifurcation strategies, single-step strategy is better. Elective upfront double-step strategy may be essential. So that it will be single-step strategy, that is better. Am I audible? Okay. Elective upfront double-step strategy, sometimes it is essential, and provisional standing, which we like very much, where main vessel and main branch is standard, and the side branch is kept alone, as it is or wired only, or kept balloon, meaning the gate balloon technique, and subsequently rewiring and low pressure balloon with the patency, maintaining a good flow to the side term. If it is not possible, then provisional double stent strategy is essential, and if not a provisional stent technique can also be done. And when upfront to stent needed to treat bifurcation lesion, if the side branch is more than 2.5 millimeter and tendency of distribution is more than 10% of the myocardium, as well as lesion beyond the ostium 10 to 20 millimeter and favorable angle or dissection at the side branch ostium. And double stent strategy, there are several types. It may be provisional double stent strategy, it may be elective double stent strategy. Provisional double stent strategy usually